So, welcome to rounds. Technical difficulties. Okay, so before we actually start showing cool cases this time, we have something exciting to reveal, and that is that we have developed an ocular pathology atlas that will be open to all and free of charge. And it will include a bunch of cases that have been annotated with some interesting, with all the diagnoses and interpretation and things like that. And this largely came about through the excitement and enthusiasm of Ryan Taylor, our previous fellow and employee. And so he continues to work on it from where he is now at Cornell University. And so this is just a quick overview of what it will look like. And then next rounds in 2 weeks, we will actually present cases directly from the atlas to show people how it works more thoroughly. So this is what the homepage will look like. So we've got all the different cases listed on the left-hand side here. So we've got normals, and then we've got a bunch of different diseases broken up by the different parts of the eye. So this is what a case might look like when you open it. I don't remember what this is. I think it's a squamous cell carcinoma in a dog, probably. And so you can see there's all these little annotations on the slide at low magnification. And when you click on those little annotations, it will zoom in and there will be little labels. You can also turn the annotations on and off. So you can just look at the case and zoom in and out and move around yourself, just like a digitally scanned slide. And so you can sort of quiz yourself on what the entity is. I think there's actually also a way to do it truly blinded, but we'll cover that in 2 weeks. I can't remember the details. But anyway, so as you can see, the little annotations are available here, so you can read about the different features that have been marked on each slide. And so that is it. So now,
So is it publicly available?
Yep, it will be publicly available. We will send out the link, and it will be free of charge. And we've decided to share this with the world. It is not free to us. Let's put it that way. But at the moment, it will be free to the world until we decide otherwise. Okay, otherwise. So let's see here. Let's get started. How do I make this go away again?
It's the fact that the chat has things popping up. So yeah. And now it'll go away.
Okay. All right, 1161. I will start. This is, yes, please. This is a dog, a 5-year-old spayed female Great Dane. The history we got was blepharospasm, hyphema, cataract, lens coloboma, blind, diagnosed with retinal detachment, and mural ocular dysgenesis. The hyphema resolved with treatment. And that was all in June of 2018, so when she was quite young. And then glaucoma eventually developed in this left eye, which is the one we have here. And the hyphema recurred multiple times over the next 4 years. So they eventually nucleated it. So they have diagnosed mural ocular dysgenesis. The other eye has iris and lens coloboma, cataract, and choroidal coloboma. So all kinds of problems in this dog's eyes. So this is the left eye. And so what we have here, we did not sample through the pupil, but here's the iris up here. And one thing right off the bat you can note is how poorly pigmented this uvea is. So there's very little pigment in the iris stroma, and then the entire choroid is poorly pigmented. So this was no doubt a blue iris, which they did tell us as well. They confirmed. Anyway, here's the lens, and it's quite cataractous. It's a little bit shrunken. So we'll take a look at that. And then here's the retina, and it is detached. And so we did multiple deeper sections on this one to fully sample everything. And let's see what we find here. Well, let's see here. All right, here's our low mag view. So here's a lens that's definitely abnormally shaped. Get the center in focus. It's abnormally shaped. Oh, wait a minute. Hang on. I'm showing the wrong case. Let me start over again. Just kidding. Wipe that from your mind.
Still abnormally shaped.
Yes, still abnormally shaped lens. Just like in the gross photo, we did not sample through the pupil here. Presumably there was a pupil somewhere, but we didn't sample it. Once again, it's a poorly pigmented uvea, so you can see very little pigment. The lens definitely is abnormally shaped. There's some mineral accumulation in it right there. So we've definitely got a good cataract. There's the ciliary body at that side, ciliary body at this side. And then as we go around, the retina is difficult. Well, actually, it's not sampled. So the retina in the gross photo is floating up here in the vitreal space. But here's the optic nerve head. And then we threw in an extra slice, which has all the good stuff happening. So right here, here's the iris. There's a little bit of hemorrhage adhered to the back of it. And then there's this defect in the limbal sclera, and there's some fluffy stuff in it. So we're going to go ahead and look higher mag at what's going on there. So it's upside down. Hope you can deal with that. So this is what a poorly pigmented uvea can look like. Sometimes they can actually have some melanocytes in the stroma. So this one does have some melanocytes, but overall, very, very few melanocytes to go around. So this is consistent with a blue iris. When we come to the peripheral cornea here, and we follow Descemet's membrane, it really doesn't stop. And it just continues right over the surface of the iris. And this is a very abnormal iridocorneal angle with iris descemetization. So we have the corneal endothelium and Descemet's membrane continuing right over the iridocorneal angle, which is no doubt occluding aqueous humor outflow and preventing aqueous humor outflow, which will definitely be contributing to glaucoma. I can't remember if that was present on the rest of the stuff up here. Let's take a quick peek. This one looks slightly more normal. We have at least some identifiable ciliary cleft and trabecular meshwork. But yeah, actually Descemet's does continue right over it. You can see it right here. So it's a pretty consistent change. So this is iris descemetization can be due to trauma, where the endothelium gets tickled and decides to migrate onto the iris, and it continues to elaborate Descemet's membrane, or it can be a congenital lesion like this, which is more likely the case here. But anyway, so it's an interesting lesion. Sometimes we do see it in cases of what we would consider to be anterior segment dysgenesis. So just a malformation of the anterior segment, which often affects the iridocorneal angle and is associated with glaucoma. So this side looks pretty good. It looks very similar to that. So let's go back over to that extra slice that we had here. So as I said, there was this defect in the limbal sclera. Also, the ciliary body is completely not identifiable here. We have iris here, and then the uvea just completely stops and goes away. And we have this limbal defect as well. And in this limbal defect, we do have a little bit of something that could either be iridociliary epithelium, or it could be retina. I'm not really sure which. It perhaps is a little bit of both and can't make up its mind. As long as we're talking about a congenitally abnormal globe, why not? And also there are some of that similar cells that are sort of embedded in the limbal sclera all the way out to here. So this is consistent with a coloboma. So a coloboma is a congenital absence of something. And in this case, the ciliary body is absent right here. We don't have any of the ciliary body stroma, at least. This epithelium / perhaps peripheral neural retina is on the surface, but the ciliary body itself is absent. As we follow it along, let's see what we pick up. Here's a little bit more maybe convincing retina, and here's a little bit of retina out here. This rounded end is consistent with a retinal tear. And we're still going back, and finally right back here, we pick up something that maybe is choroid. In blue eyes like this that have very, very poorly pigmented fundus, like in choroid, the choroid is normally very, very thin and actually almost difficult to discern in a normal non-colobomatous eye. But in this case, I think this is actually the choroid here, so it has picked up. So basically we had a ciliary body and perhaps peripheral choroid coloboma up at the front there. And let's see here. So unfortunately, we didn't sample the retina very well. Let me go back and take a look at sorry for the wandering. the optic nerve, with the big old piece of chunk stuck on it. So they nucleated this eye for glaucoma. We didn't sample the retina very well, but the optic nerve head, which is probably a little bit tangentially sampled here, is a bit gliotic. Let's see out. And the lamina cribrosa right here is maybe a little bit recessed from the choroid, but once again, the choroid is so hard to discern in this eye. Anyway, so let's go back up and look at the lens. So we've got lens capsule wrinkling. And we've got degeneration and liquefaction of the cortical lens fibers.
A bit of retina there.
Oh, sorry. Yeah, little ball of retina right here. Yep. And then there's some of that mineral that we looked at lower mag. So this is a hypermature cataract. This posterior lens capsule, let me check here. So you always have to make sure that your lens is actually oriented in the proper way once you get the slide. And in this case, I think it is, in part because I think it was fairly well anchored here in this globe by this membrane. So you have to convince yourself that you're truly looking at the posterior lens capsule, but it's actually quite thick for a posterior lens capsule. So this is just a congenitally abnormal lens. And so one of the features of congenitally abnormal lenses is that the posterior lens capsule is actually much thicker than it normally should be. So this is reading the book in that case. So this is probably a congenital or a juvenile cataract, at least juvenile. Okay, I think I've covered all of the main features of the slide. So let's.
Do you think the choroid is like hypoplastic or difficult to identify because it's poorly pigmented, or both?
I think well, in this case, I think it's a very poorly pigmented eye. And so just finding the choroid is difficult in general. So I don't think like the entire choroid is gone. I think that choroid is present in most of this eye. Up there in the peripheral where we had the gonio slice that we were looking at, I think the peripheral choroid is probably jacked up, absent.
If you pay attention to blue-eyed dogs in general, the choroid looks way, way thinner and less obvious than normal, even in, you know, dogs that don't have glaucoma or any other secondary lesions. So I think that it's part of being the blue eye plus glaucoma, and you know, I think that's specifically congenital type of thing. But it could be.
This eye was in the dog for a long time. If it hadn't developed glaucoma or perhaps complications of cataracts, it would just have been left alone.
Yep. Yeah, much like the dog's other eye, they'll hopefully keep it in there in the head. One thing I didn't talk about is the cause of the retinal detachment and tear, and I don't know the answer. So you can actually have congenitally detached retinas that may or may not have connections to the peripheral area. I'm not sure about that, but we definitely had vitreal degeneration in this eye, and so it may have been the retinal detachment may have been a consequence of the vitreous tugging on the retina and pulling it off the back of the away from the RPE. So that may have been a secondary retinal detachment. It's hard to say. Okay, great. Let's move on to the next one. This is another cool congenitally weird eye. All right, this is a cat whose name, if I say it, might be known to people out in the world, so I won't say it. It's got a funny name. Anyway, this is an 11-month-old. I know, just gonna tease you. An 11-month-old spayed female domestic short-haired cat. I will tell you, it was an island cat from Turks and Caicos. But anyway, she was diagnosed with anterior segment dysgenesis in this eye with corneal perforation that they decided was a previous corneal perforation. Buphthalmia, an incipient cataract by an ophthalmologist. They included the report. And the cat had been on dorzolamide for this eye because of glaucoma, presumably. And let's see here. They say duration of problem since birth. So I guess this cat has had a congenitally abnormal eye since birth, or since eyelid opening at least. And the other eye was normal. So here's the eye. Right off the bat, you can kind of appreciate that the pupil is ever so slightly abnormally shaped. So it's fairly round up here, but it does have this little indent here. Inside the lens, the globe, sorry, you can see this opacity, which is probably the lens right here. And the cornea is vascularized. You can see some of those little blood vessels coming in from the periphery, and it's a little bit cloudy, so there's probably some corneal stromal edema. And then when we hemisected the globe, we found this really awesome connection of both the iris right here and the lens to the posterior cornea axially, so right in the center. The retina is also detached, and the lens itself is kind of opaque, so it's a cataract. And so, yeah. So let's jump right in to the slide. This time I'll show you the correct eye. And what made me immediately realize that I wasn't truly showing you the wrong eye is that the shape of this lens reminded me of a snack from Brazil called coxinha, right?
Yeah.
I saw that and I was like, oh my God, looks like an edible, delicious thing. Okay, anyway.
Oh man, now I remember thinking about it. Thanks, Ian.
Sorry. Anyway, so I got multiple deeper sections of this eye because in order to sample the beautiful axial lesion, it took a few sections. But here's one of them. So what we do see is that lens and a little bit of iris tissue reaching up toward the axial cornea, which we'll take a closer look at to show you what's going on there. The little spot there in the iris is a little bit of inflammation. So like many good cats, there's some sort of lymphoplasmacytic anterior uveitis. The ciliary cleft is not very apparent here. So there might be something malformed about the iridocorneal angle. The lens obviously is abnormally shaped, and then there's some mineral in there. So a cataract. And then the retina is detached and it does not really have its normal layering in this image, in this section. So that's definitely atrophied. As you might remember from the gross photo, it really did attach to the optic nerve head. That's always something important to note when you're cutting globes from abnormal eyes from young animals, is whether or not a detached retina actually was ever attached to the optic nerve, because you can actually have it where there was never any attachment to the optic nerve head. In those cases, the retina should not have blood vessels. So in order to have blood vessels, the retina needs to have a connection to the optic nerve head. Okay, so let's go higher now. Okay, so here we are in the axial cornea. And though you may not be able to pick up Descemet's membrane at this magnification, one thing you can pick up is that the deep corneal stroma here is a little bit abnormal, right where that uveal tissue and the lens is reaching up toward. There's also a few little dit dots here in the corneal stroma, which are blood vessels. And so now we'll take a closer look. And so, we have an axial defect in Descemet's membrane. Which is important because that is one of the key features of Peters anomaly or anterior chamber cleavage syndrome, which in human medicine, it falls under the umbrella of anterior segment dysgenesis. And then there's like a whole bunch of different flavors of anterior segment dysgenesis. So right here, you can see the original layer of Descemet's membrane is all wrinkled here. And then there is regrowth. So there's doubling of Descemet's membrane, and you can see this continues along here. And in at least one of the sections, Descemet's membrane, it's hard to make out here, but I think it's right here, does continue onto that iridal tissue. So there's again descemetization of the iris. It just happens to be axial here as opposed to peripheral that we saw in the last one. And yeah. Okay. This axial defect in the deep corneal stroma and Descemet's membrane with iris involvement, and in this case, lens involvement, is pretty classic for Peters anomaly, which is a rare form of ocular congenital malformation or developmental malformation. And where, so normally the lens kind of sprouts off and sprouts off from the cornea. And in this case, we just had incomplete disconnection from the cornea. And let's look at our iridocorneal angles. So remember, this cat had glaucoma. It could have been associated with if there was pupillary block, but it didn't really look like there was pupillary block either grossly or histologically there. But we do have quite a bit of inflammation, which could be associated with a cataract or an unknown infectious disease. There's also a good pre-irital fibrovascular membrane that's reaching around, and the ciliary cleft is inapparent. Descemetase actually does continue around a little bit, so there might be some degree of descematization of this iridocorneal angle to explain the decreased aqueous humor outflow and the glaucoma. We can zip over here. Here it's the epiphyme is causing ectropion uvea, so you can see that iris pigmented epithelium being pulled around. And so that's a good indication that there is a membrane of some sort on the front of the iris. And once again, on this side, the ciliary cleft is not open. You can kind of make out some of the ciliary, trabecular meshwork. It's not completely collapsed. And then the limbus is a little bit indistinct here. So normally the peripheral cornea meets the scleral collagen in a fairly straight line. And I think it normally angles this direction, actually. And here we kind of have, if you follow the pigment, which is usually present in the limbus, right at the limbal line there, it sort of angles back the other direction. And so also we don't really see much in the way of angular aqueous plexus, at least up here where you'd think those little channels should be to collect that aqueous humor. And so there are some, but they're just fairly posteriorly displaced. So this is all many of the different lesions of something like anterior segment dysgenesis. This is one of the flavors of anterior segment dysgenesis. And so we've got lens capsule wrinkling here and a bunch of cortical lens fiber degeneration and mineralization. So we've got a good cataract that happens to look like an edible treat from Brazil. And then here's our retina. So it's a little bit disorganized. You can see that the outer nuclear layer, which is the photoreceptor nuclei, is intermittently present. There's also some big wide spaces in it. So that's retinoschisis that often develops secondarily to retinal detachment, prolonged retinal detachment. It can also be a congenital lesion. So in this case, I don't know which came first, whether perhaps there was, let's see, did we diagnose? Yeah, the vitreous was liquefied in this globe. So once again, there could have been a secondary retinal detachment associated with vitreal degeneration. Let's see here. I didn't find very many ganglion cells, but you can see some of them here and there. And then remember, I told you to always check the retina for blood vessels to sort of more fully diagnose a congenitally abnormal retina. But you can see we've got some nice blood vessels here. So this retina did have a connection to the optic nerve if you didn't have the benefit of being able to see the gross photo or good gross notes. Okay, so that's all I can show you for this cool eye.
So the retina, this is a good point that retinoschisis can be both secondary. But in humans, retinoschisis is more often diagnosed with a primary genetic disease in babies. So it could also be something part of the congenital type of a retinal dysplasia. We just can't tell because Gina's absolutely right. There's that cataract and the vitreous degeneration, the detachment between the cause of it. So some of those things we're not able to address later in the process.
Right, so let's look at what we have here. All kinds of okay, all kinds of diagnoses here, but ultimately I think there was congenitally abnormal formation of the anterior segment of this eye. So Peters anomaly, once again, that should be associated with this axial deep corneal stromal defect that usually involves Descemet's membrane and the iris. And then some other problems as well. So there you go.
Yeah, I like the use of lenticonus for that lens.
Yeah.
I think it's not used very often, and when it is used, it's not adequately used, but this is a perfect example.
Yeah. Okay, thank you for bearing with me. Now, next.
All right. Hello, I'm Megan, and I'm going to start with a ringtail cat today. Ringtail cats are basically a relative of raccoons. They kind of look like you might expect. They kind of remind me of lemurs, actually, a little. But anyway, you can Google ringtail cats. So this cat had significant corneal thickening and edema with areas of pigmentation. Previously had undergone thermokeratoplasty. And some pinpoint foci of scar tissue are present because of that. and they couldn't see anything past the cornea. Once we go to the gross photo, or if you're already looking at the gross photo, you can probably already tell why. So this ringtail cat has some other history that I won't share, died of unrelated causes, and we have both eyes. So on the gross photo here, this is both globes side by side. They were basically both submitted in the same jar. So right or left, it's hard to tell which. But either way, they have very similar presentations. So the cornea kind of ends here roughly on this side and ends here on that side. So you can see that the cornea is really severely thickened. And in some areas, it almost looks like this cat has two corneas because there are these big empty spaces right in the middle of the stroma. And it's a similar thing on the other cornea, kind of here's another sort of space there as well. But the rest of the eye is kind of unremarkable grossly. So let's take a look at that cornea histologically. One. I'm going to pick this one. Actually, it's a very small eye. All right, so here's the cornea up here. There's still stuff on it. So at the periphery of the cornea, we have a much more normal looking stroma. We still have the maintenance of those lovely parallel oriented stromal fibers as it should be. That's how you get your optical clarity in the cornea, or part of it. But as we go towards the axial cornea, the cornea is severely expanded by clear space. There are basically just these enormous lacunae. Sometimes they have a little bit of hemorrhage in them even, but otherwise just sort of empty space. And then even in the stroma surrounding those lacunae, we have sort of a paler staining, pale eosinophilic stroma with sort of separation of those stromal fibers. So this is what a very severe corneal edema looks like, and this is what we would also refer to as corneal hydrops. So often histologically, we can't be sure, we can't confirm corneal edema ourselves. And formalin fixation in particular, there can be artifactual separation of the stromal fibers, very, very frequent. So oftentimes corneal edema in a milder forms can be more of a clinical diagnosis than histologic diagnosis. In a case like this, corneal edema is absolutely, there's no question histologically. So kind of interesting to see. So why the edema? And that's kind of a very interesting question. Let's go deeper on the back of the cornea here. So there are some very interesting changes back here. Start right there. Nice. So the corneal endothelium in sort of transverse section like this will typically look like the single layer of low cuboidal cells, as you probably already know. Oftentimes they'll have a little bit more cytoplasm to them though. That cytoplasm is often kind of vacuolated in our formalin fixed sections. These guys are very flattened. They're almost like a spindle cell at this point. And the nuclei are often very widely spaced. So here's a nucleus of a corneal endothelial cell. There isn't another one until way over here. So there's sort of some irregularities in spacing, lesser numbers of these cells, and they look a little bit abnormal. The interesting thing about corneal endothelium is that in flat section, if you ever serendipitously happen to catch it flat on a histologic section, or of course there are many people who have done it on purpose, it's very, very pretty. It looks like a hexagonal mosaic is a good word for it, I think. Kind of like a beehive. And oftentimes in this condition, it'll be very disarrayed and not as sort of nice and closely packed as of a mosaic as usual. And I would strongly encourage you to find papers with some electron microscopy and other things like that to check out endothelium. It's very cool. The other feature that is very interesting in this case are these. If you follow the back of Descemet's membrane here, there are often these little bumps here. So it sort of like projects out. And so these are guttata, which in human corneal endothelial dystrophies, actually, so like Fuchs corneal endothelial dystrophy in humans, this will have a very similar histologic appearance as this ringtail cat, which is just really cool. So this is another feature of corneal endothelial dystrophy. And indeed, the history that I withheld from you is that this ringtail cat was already diagnosed clinically with corneal endothelial dystrophy and had been dealing with corneal edema probably for much of this cat's life, but not the reason why the cat died. Or just a really cool case and neat histologic correlates.
What are these
Yeah.
Mufasa things made out of?
Mufasa things?
Yeah.
Oh, Gutata?
Yeah.
I think they're just Descemet's membrane, right? Can someone tell me?
Yeah, it's a poorly formed Descemet's membrane type, or basement membrane, in this case, Descemet's membrane material produced by the dystrophic or the abnormal endothelial cells.
It
So
even, go ahead.
that term is a fun name. If you're speaking Latin languages, recognize gutta as like gota as like a drop. So those are like tiny drops. And many gotae, gutta, or guttata, so multiple drops in the Descemet's membrane. Makes it easier to remember. And also, if you look around, Megan, I think you might see kind of a two-tone sort of
yes.
coloring of Descemet's membrane. So doubling of Descemet's membrane is another possibility. And also areas where you don't see endothelial cells in here, which goes back to what Megan was saying. Imagine like a flat mount where some of these cells, so corneal endothelial cells, they're post-mitotic theoretically. But so when you start losing those endothelial cells, the next cell over kind of stretches out to sort of fill up the gap. And what you're seeing here basically, they might not be necessarily naked areas of endothelium, but just areas where these cells are stretching out and you don't get to see the whole profile of the cell.
So even though you have Descemet's membrane or even a duplication of it, it does not provide a barrier to the influx of fluid to the cornea. Is that?
Yes,
Okay,
this
go
is a
ahead.
good question.
Thank
So the question was, even though we have an intact Descemet's membrane and even a double Descemet's membrane, we don't have enough of a barrier to prevent edema. So there are several things that do maintain a relatively dehydrated state in the cornea, which is very important to maintain optical clarity. As we have seen, when you get fluid in the stroma, optical clarity goes out the window. Purely barrier function is part of it. So Descemet's membrane and the corneal epithelium provide basically a barrier to prevent fluid from going in. But the kind of mainstay of maintaining the stroma in a relatively dehydrated state is basically active pumps in the corneal endothelium. So the corneal endothelium sort of has like a key role. And so the dystrophy, that's part of the reason why dystrophies like this can end up in this really, really severe corneal hydrops, because you lose that like active pumping of the fluid out of the stroma with a dystrophic endothelium.
It's crazy to think that those endothelial cells can manage to keep the entire cornea dehydrated because it's so
Right.
thick.
Right?
Like,
They are.
are they just basically creating a gradient?
Yeah, it's a sodium potassium pump type action.
That's crazy.
Sodium potassium pump. Yep. They are small but mighty and beautiful.
Yeah, that's why, in humans, on us, that's very big deal, right? Because corneal flux dystrophy is relatively common change. And it causes visual acuity problems, very severe visual acuity problems because of hard to control corneal edema.
Yeah, apparently it looks like cloudiness and a glare, maybe.
Isn't that one of the more common reasons for corneal?
Transplant?
Yeah.
Yeah, exactly. And it's funny, I remember going to the medical school for readouts with their ocular pathologists, and it wasn't uncommon for them to have as a specimen on the slide, a tiny strip of that just Descemet's membrane. And if the clinicians would go there as a diagnostic purposes, or sometimes maybe just treat them, just take a flimsy piece of Descemet's membrane, they're in bed, and they'll discuss the shapes of the guttae for about 10-15 minutes on the 0.5 micrometer section of something, and I'll be like, oh, geez. I got us taking the eye here for you guys. Ocular pathology in the veterinary world is much more interesting.
Are there therapeutic options to dehydrate?
Yeah, I think some types of like, corneal, what are they called?
Hypertonic saline is usually.
Yes.
Saline. There are,
Yep.
Jesus,
Somebody put that flap over the cat eye when cats get really mad.
cat eyes. So in animals, you can do like a, third eyelid flap on top, and that would, corneal hydrops really helps. After a while, depending on the cause. For example, if it's not like dystrophy, but like a ruptured decimus membrane, and there's trauma, you can do like a corneal flap, and that would stabilize that cornea until that decimus membrane defect, recovers. Contact lenses, that's what I was trying to get.
Contact lenses, yeah.
Use some contact lenses to help.
So
Are there any breeds or species or anything that you think of when you're talking about?
Boston Terriers.
I don't know how much you know, I suspect, but
Dogs, it's more commonly seen in dogs. I think you guys can correct me. Yeah,
Boston Terriers, yep.
Yeah,
So-
but for us, we rarely get to see them on histopathology because it's a clinical diagnosis and it's not, it's not painful. It's just corneal edema, so it's clinically managed until either the animal dies, like in this case, or there's a secondary lesion, which makes it really hard for us to make the diagnosis. Because, what usually happens from a pathology standpoint, they have corneal edema, then they have ulcers, then they have secondary corneal disease. By the time you receive it, it's so chronic that you can't even make the main diagnosis.
So in summation, some of the therapeutic options available, hypertonic saline, sometimes they'll place temporary contact lenses or third eyelid flaps, especially if the cornea has other issues like ruptures or descemetocele or something, maybe more descemetocele than ruptures. I'm not a clinician, as you can tell. And then in human land, they will typically do a corneal transplant. We actually recently watched a procedure too, where in human land they can actually like just scrape the endothelium off the back of the cornea and do like a decimase membrane or endothelial transplant, like purely, which is pretty crazy. From a veterinary standpoint, it just is like, wow, that's a fiddly surgery. But in any case, so dermatokeratoplasty is also a therapeutic option, by the way, which was performed in this cats, although I am not entirely sure how it works. So I would encourage you to do some reading on that. Definitely still not a clinician. And then also Boston Terriers in terms of like more common breeds that a veterinarian might see represented with endothelial dystrophies. All right. Any other questions or comments? Okay. Here's some diagnoses, and I'll move on to the next case. A sea lion. Eyes removed post-mortem, and once again, cause of death unrelated to ocular disease. The lens removed from the left eye, and some chronic corneal fibrosis. The left eye had developed glaucoma, which they note as uncontrolled. So those are the main things that I'll point out off the history. So we got both eyes. We also got both eyes in the same jar, but in this case, because one eye had the lens removed, we could tell which was which. So this is the left, this is the right. As you can see, in the left eye, there's no lens. There you go. There's also this lovely sort of sparkly, it's probably harder to see the sparkles in this picture, but grossly, asteroid hyalosis is kind of sparkly, so that you know. Very important scientific fact. So it's sort of like the Milky Way in here, and that's asteroid hyalosis grossly. The interesting thing about this is on the right eye is more commonly what sort of the aqueous outflow pathways look like grossly in a sea lion. It's sort of this like lovely mesh looking appearance. Over here in the left eye, though, there's basically none of that. It looks very tight and collapsed and, not very open and flowy at all. So that's worth pointing out as well. Back here, we probably wouldn't have called anything grossly, but I'll point it out just because of histologic features. There's a little bit of lifting of the retina and maybe a little bit of like hazy stuff underneath. No way you would call that grossly. I'll show you the histology though. Because for example, over here, this is totally an artifactual retinal detachment. Very, very common to have the retina detach artifactually as you cut in these eyes. It's common to get bubbles trapped underneath the retina as you gross these eyes in. And all of that is just artifactual change. So you don't want to overinterpret grossly. In the right eye, the only thing I'll point out on the gross is this very subtle thing right here. In the episclera, we have these two little whitish, off-whitish bumps, and they're very crisply demarcated. When these weren't in cross-section, these basically look like these elongate, sort of oval-shaped structures, sort of tight against the eye in the episcleral connective tissue. And most likely what these are cyclosporin implants. So that's an immunomodulatory drug. Sea lions often get cataracts, they often get corneal disease, and immunomodulation is a typical for that, inflammation from that. So that is most likely what those were, and that's what they look like grossly and in cross-section in the episclera. So that was neat. We'll go to histology.
Size difference, just magnification.
Yes.
Yeah, because you have
The scale bars down here, you can see this one is a little bit wider or bigger. Yeah.
It's the same exact scale bar.
Ocular disease.
Perfect rounds. Yeah, that is why it's because there was a little bit extra optic nerve on this one too. So I could have cut that off and then taken the photos. At that point, it might have looked more symmetric, but
That's a great question.
it is a great question.
Yeah.
Yes. Sorry.
I wanted to clarify that captive sea lions are prone to developing these things,
Yeah.
not out in the wild. Captivity is a problem for their eyes.
Yes.
Oh,
Oh,
okay, just kidding.
Interesting. So more commonly known in captivity, but we just had a comment that wild ones also get it. Cataract and corneal disease. All right. Also, I hope it's not annoying if I repeat things. I just think that people who are further from the microphone may be less audible. All right. I'm gonna throw up the left eye, which is the one that's sort of the main one of interest. See if we can get a subgross. So here is the eye. We actually have this, let me see if I can get it in focus and in the middle. We actually have these little balled up pieces of pink stuff in the posterior chamber, which we'll look at closely in a hot second. You can again see that the sort of flow holes here are pretty collapsed, like the angles are pretty narrow and collapsed, and there's lots of purple here, which we'll look at closer in a second as well. Going to the back. The retina is a little awkwardly sampled, but like I said, never would have called it grossly, but histologically, there's something interesting underneath this retina, and we'll look at that closer too. All right, so this eye has been rotated 90 degrees clockwise. We have a cellular infiltrates in the anterior uvea. Mostly, these are lymphocytes with fewer plasma cells. And it's actually quite a large number of cells infiltrating this anterior uvea. And in addition, you'll see these little guys scattered throughout these lymphocytes. And these are macrophages that kind of have nuclear debris in their tummies, sometimes called tingeable body macrophages. And it was interesting that there was a fair number of those there. And it's kind of like sheets of lymphocytes with only occasional plasma cells. So in this case, it reminds me a lot of cats. So briefly talking about domestic cats, in their chronic uveitis, they will sometimes develop sort of discrete foci of lymphocytic inflammation, and then up to and including like a follicular anterior uveitis. Basically, they can develop well-differentiated lymphocytic follicles in their iris. So in this case, there were some interesting features. Oftentimes, it's more of a mixed plasmacytic infiltrate. In this case, it was mostly lymphocytes. They had the associated macrophages. There are occasional mitotic figures, but that doesn't really tell us anything. If I can actually go over to where there was one. So we commented on some of these somewhat atypical features to this pretty severe uveitis. However, the most likely reason for why it looks like this is because this guy has had chronic, very long-standing lymphoplasmacytic uveitis, probably lens-induced. Just pointing that out. There was a mitotic figure over here. I'm not going to spend our time trying to find it. So that's the cellular infiltrates. There is a fibrovascular membrane on the top of this iris that is crossing the angle. So we do actually have pith and pass in a sea lion. You can see that the anterior iris kind of ends right here where there's this little layer of pigmented cells. This is all membrane with a couple of lymphocytes scattered within it.
Just fell off pith and pass. So.
Oh, sorry. Pre-iridal fibrovascular membrane, that's the pithum. And then peripheral anterior synechia, that's the pass. I need to remember that the shorthand is not necessarily widely known or used. You can even see here in the corner where it crosses through the corneal angle, these tiny blood vessels that make up the vascular part of fibrovascular. So that's that. Let's look at the eosinophilic stuff in the posterior chamber. It is a snail. Excuse me, my voice seems to be going. It's not a snail. It looks like a snail. So this is a folded lens capsule. We can see the posterior lens capsule here, which is thinner, and it develops this lovely little tight curl. You can kind of think of it like piano wire under tension when it finally snaps, like oftentimes in cartoons and for stuff too, like it kind of curls back, you know, like a little curl like that. So this is a true lens capsule rupture. We hardly need proof of that, but that is what it looks like. And here's a break in anterior lens capsule as well. And there aren't really any normal lens fibers left. They've basically been resorbed or all removed, more likely, surgically. And then the inside of the capsule is filled with a little bit of collagen, which was probably laid down by lens epithelial cells, which will sometimes remain and sort of do their thing. So this is kind of a post-operative cataract eye. Like that.
Do they put IOLs in these animals?
It's a good question.
Doesn't seem to have like a large enough, maybe IOL for something like this.
Good question. I think they make them big enough for horses, so. Yeah.
That's a good point.
But the refraction.
Just curious if it was just a lack for like a intracapsular lens extraction right away.
Kind of the SeaWorld.
The question was, could we put IOLs in a sea lion? And the answer was, there are big enough IOLs like for horses, but probably the refraction wouldn't be right for going underwater. So probably not. All right. The retina back here, we have sort of artifactual incomplete sampling at the edge, but we can see that the retina is detached, and we can tell it's a real detachment in particular because there's stuff underneath it. And this stuff is eosinophilic proteinaceous material, and you even have a couple of little macrophages admixed with it. So we know that this material is real. So this is little tiny serous retinal attachments sort of centrally and in the back of the eye. So we commented on that and uncertain of the cause. We're sort of all like, we're curious about the necropsy findings if there are any, but we don't have any information on why this sea lion died or what else was going on with the rest of the body at the time. There aren't really any clear glaucomatous changes as we know them in like a dog or a cat. The optic nerve looks reasonably okay. I think, yeah, there's a good number of retinal ganglion cells, at least at our examined level. But it's tough to tell what glaucomatous lesions might look like in various species. We don't have a lot of well-defined histologic correlates for some of our more exotic species. There's that. And I think that's all I wanted to show you in this eye. Briefly, the corneal changes are so mild that I'm not going to show them. There's a little bit of disorganization of the stromal collagen fibers. Over here in the right eye, though, I wanted to briefly show you just because it's kind of cool. So back to where we had on the gross, those cyclosporin implants, here they are histologically. There are these very sharply delineated spaces in the episcleral connective tissue or sort of subconjunctival connective tissue. And there's a little bit of fibrosis around these. And then inside, kind of a little bit folded up and funkily sampled, there's this poorly staining material. If I use digital polarization here, aka I'm using my finger, digital polarization. You can really see the material there. That is basically the cyclosporin implant all folded up. So that's kind of neat. This sort of like slight fibrotic reaction around this is similar to what we'll often see in the lining the blebs of gonio implants. And presumably part of the reason why a lot of those implants will eventually need revisions of their blebs, like taking the roof off of them, because they develop this interesting sort of fibrotic reaction. So I just thought that was neat. Oh, go ahead. Oh, yeah. Oh,
A lot of our angles too.
yes.
It's just beautiful, look at that.
This is kind of what we're looking
The
for.
archipelagos of Carcinoma islands.
Just to stop, the question was just to stop here and look at the normal side for a little bit, and especially compared to the abnormal side. So there you go. Yeah. Nice open pectinal ligaments, nice open meshwork. So that's it.
If you end up with that fibrotic capsule around the gonio implant, or not the gonio implant, obviously it doesn't work then, or around the cyclosporin implant, does it stop working?
Good question.
Does it keep diffusing through the,
You don't have that on your lifespan anyway, the cyclosporin in the implants.
okay,
Interesting.
So it's not really an issue, we just replace them.
okay.
The question was, would the fibrosis around the cyclosporin implants stop them from working? And the answer was, the life of the cyclosporin is probably too short for it to matter anyway.
So when you're replacing them, you're basically putting in the totally new, and you're not using the same bleb area. Okay.
Yeah, sometimes you remove the ones that you can find it, other times you just leave all of them. You know, what you should. Gotcha.
So that's it for the sea lion. And that's it. I will give up the seat.
For lesions with lesion virus.
No, not in sea lions. The question was, do we see ocular lesions with calicivirus in sea lions? And the answer was, we don't really. All right. Oh, it does happen, but it's not a feature. There we go. All right, now I'm going to move. All right, we've got 5 minutes left. I will be swift. We'll do only one of these, but that's all right. All right. This was a 14-year-old Siamese cat mix. They submitted to us both the right eye and a mass from the left lower eyelid. So eye from one side, eyelid, mass from the other side. Remember that. And the only history they gave us was corneal perforation in the right eye and pigmented mass of the left lower eyelid. They also told us that it had herpes virus, hypertension, chronic kidney disease in a 14-year-old cat, and IBD. So they were not wrong about the corneal perforation. And when I trimmed this grossly, I didn't actually appreciate what was happening here. I thought like this was really edematous cornea, and then there was a big perforation here. That turned out to actually not be true. This isn't cornea at all. This is really edematous iris. And there's just no cornea. Like this is limbus and sclera, and this is limbus and sclera, and like there's a tiny nubbin of cornea here, and that's it. This up here is third eyelid that we have in cross section. So the cornea is just gone. The iris is completely prolapsed through that space where the cornea used to live. This is all inflammatory exudate, which is obviously not surprising given the fact that there is nothing, like it's not like, oh no, we don't have the
corneal epithelial barrier or the Descemet's membrane barrier. We just have no barrier. It is an open space. So the globe is filled with pus, and then the lens is not something that we can appreciate anymore. Given that it is free to move about the country, it is not surprising. So let's go ahead and look at the slide 14. Just you wait, it's so exciting.
It's a good slide.
All right. So here's our globe. I'm gonna put this in the middle. So, yeah, sure. All right. So like I said, this is the iris that is now performing the role of the cornea, or trying to. This is also iris attempting to perform the role of the cornea. This is sclera right at the limbus where the cornea would have begun. Here we have third eyelid. On the other side, we also have sclera that kind of stops right at the limbus. Maybe there's a tiny little bit of cornea. And then this sort of limbal area is expanded by purple, which always means cells, usually means cells. And then there's also kind of this lining of purple that wraps around the iris, which is maybe difficult to appreciate from this magnification, but it's present on both leaflets. And then we've got all this pus and fibrin in the center and no lens to be seen. The retina is detached, unsurprising, but given our time constraints, we will focus on what is happening at the front of the eye. So here we are. This is that limbal area. This is kind of the remnants of corneal stroma, maybe. Here's the iris that we were seeing before. And then we have all of this increased cellularity in these tiny little like islands of cells. And these islands of cells don't belong here. This is not their home. And then these same cells are extending. This is a broken fragment of Descemet's membrane. They're wrapping around and coating the inside of Descemet's membrane fragments. They're also wrapping around and coating the surface of the iris. They continue on. You can take my word for it, but essentially they coat pretty much every surface that they can get to. And they can get to a lot of surfaces now that there's no cornea anymore. If we look at the cells more closely, they do some really beautiful things. So these are neoplastic epithelial cells. Some of the spaces that they're lining are actually blood vessels, so they're coating the endothelium of these blood vessels. I don't think this one is necessarily a blood vessel, but some of these spaces are. These cells have a lot of mitotic figures, a lot of atypia. They sort of slowly progress and don't mature in any kind of orderly way, but there are some places where they sort of keratinize. And then in the center of these spaces, there's a lot of cellular debris with neutrophils and sloughing necrotic neoplastic cells. And then within one of the iris leaflets, here's our iris coated by neoplastic epithelium. Over in this iris leaflet, one of these islands of cells is just making oceans of keratin, which are mixed with a bunch of neutrophils and cellular debris. There is also some really large bacterial colonies that are present. These oceans of solid dark blue, that's all bacteria, which is just opportunistically colonizing this open space. So I'm going to show you. If you have to go home, that's okay, but I'm going to show you what was going on in the eyelid of the other eye.
Got oceans, you got pearls. There's a fun day.
Is it beautiful? So here's the eyelid of the other eye. There is also an epithelial tumor here, but this epithelial tumor has got a little bit of a different morphology. So where the other one was forming these islands of things with keratin in the center, this one is forming these like papillary projections on stalks with all of these little like ribbons of epithelium palisading out. If we go closer and look at them, there's never any areas of keratinization. These cells are more columnar. They really have more of like an orientation where the nuclei are more basal. And then you've got this epithelium and these little projections that are shooting off into these large open spaces, which have some proteinaceous fluid and neutrophils and